Good afternoon. I want to thank you for joining us for today's webinar. The webinar is titled Tales from the Front Lines, Alarming Rise in Hospitalizations Related to Opioid Use Disorder in the Era of COVID-19. Our panelists today are Dr. Richard Dart, Dr. Dana Clifton, Dr. Noel Ivy, and Siobhan Hamilton. And I'm Richard DeVito. I am the managing editor and publisher of the Journal of Emergency Management, as well as the Journal of Opioid Management. Briefly, we're going to have opening remarks and a welcome, then we'll have our speaker presentations, and then we'll have curated Q&A via chat and some closing remarks. This webinar is presented by the Journal of Emergency Management as well as the Journal of Opioid Management. This is a unique situation where we publish both journals, and each of these journals touches on this pandemic in a different way. Journal of Emergency Management obviously deals with the overall COVID-19 pandemic, and Journal of Opioid Management deals with the opioid epidemic, if you will. Some people may call it a pandemic. So we're pleased to bring these two different audiences together for a presentation dealing with this particular topic. Funding for this training and the webinar have been provided by the National Institutes of Environmental Health Sciences of the National Institutes of Health under the award number U45 ES019350. And this is in cooperation with Nova Southeastern University and Dr. Cohen and his team down there at Nova Southeastern. Thank you very much for your support. The details and recording links for this webinar will be located on our Journal of Emergency Management webinar page. Please click back to there to get recordings of the webinars as well as the handouts and other details. Also, please look for a post-webinar survey from us. It's very, very important that you give us honest feedback on how we did with the webinar, and we will do our best to include your feedback and make our future presentations even better. Thank you. Quickly, the opinions of the panelists and our moderator are their own, and by attending this webinar, you confirm your acceptance of being recorded in voice or an image. Please send all questions through Zoom's Q&A function. That's up at the top of your screen, depending on how your screen's laid out. And we'll use that for moderation and to be asked. In addition, please ask concise questions, cite your sources, and limit opinion and criticism. Please do follow up with our speakers. They're very interested in your feedback and any additional questions, and that they can share their intelligence and their solutions with you. Please send future topics, comments, and suggestions to gem@pnpco.com. And again, thank you for participating. The opinions of the panelists and the moderator are their own and are not to be considered medical advice. If you're in crisis, please dial 911 and get immediate help or contact your physician. Briefly, I'd like to do introductions for our panelists. This is Dr. Richard Dart. Dr. Dart is certified by the American Board of Emergency Medicine and the American Board of Medical Toxicology. Since 1992, he has served as the director of the Rocky Mountain Poison and Drug Center. He is the executive director of the Research, Abuse, Diversion, and Addiction-Related Surveillance, the RADAR system. He has published more than 250 papers and chapters, as well as served as the editor of the textbook, The 5-Minute Toxicology Consult, and the 3rd edition of Medical Toxicology. In 2002, he was recognized with a special citation from the Commissioner of the U.S. Food and Drug Administration. He was the 2004 recipient of the American College of Medical Toxicology Matthew J. Elhorn Award for Excellence in Medical Toxicology. He also serves as the deputy editor of the medical journal Annals of Emergency Medicine and is the past president of the American Association of Poison Control Centers. Dr. Dart is also a past conference co-chair of our International Conference on Opioids. We're also pleased to have Dr. Dana Clifton. Dr. Clifton is the assistant professor in medicine and pediatrics at Duke University. Dr. Clifton attended the University of North Carolina at Chapel Hill for undergraduate studies. She attended Duke University for her medical degree and was inducted into the AOA. She is board certified in internal medicine and pediatrics. Dr. Clifton worked clinically as a medicine/pediatrics hospitalist, rounding on both general medicine and pediatric services. Dr. Clifton is a co-medical director of Project Comet, a program designed to improve the care of hospitalized patients with opioid use disorder and withdrawal at Duke University Hospital. She is the associate medical director for quality improvement within the Duke Hospital Medicine program. And Dr. Clifton is also the associate director for pediatric undergraduate medical education and pediatric sub-internship director. Thank you for joining us. Our third present panelist is Dr. Noelle Ivy. Dr. Ivy attended the University of North Carolina School of Medicine and completed her training in internal medicine at the Oregon Health and Sciences University Hospital in Portland, Oregon in 2010. From 2010 to 2017, she worked as a hospitalist at the Charles George Veterans Affairs Medical Center in Asheville, North Carolina. She joined the faculty at Duke University Hospital in 2017. She currently serves as the co-director of Project Comet, which stands for Caring for Patients with Opioid Misuse Through Evidence-Based Treatment. This is a quality improvement project seeking to improve care for hospitalized patients with opioid use disorder. Additionally, she is actively involved in the clinical trial work for hospitalized patients with COVID-19, and she has a special interest in physician wellness. Thank you for joining us. And our last presenter today is Siobhan Hamilton. Siobhan is a licensed clinical social worker with a Master of Social Work from Fordham University and a Bachelor of Social Work from Iona College. She has worked in behavioral health field since 1999 and has experience in community behavioral health administration. Siobhan has joined Duke University Hospital in 2019. She is currently an inpatient clinical social worker where she is a member of the Opioid Use Disorder and Withdrawal Consult Team, also known as Project Comet. I want to thank you for joining us. At this point, I'd like to turn our presentation over to Dr. Richard Dart, who's lead us off with an overview of his surveillance data with regards to opioids in the United States during the past year and a half. So at this point, I want to thank all of our panelists for joining us, and I appreciate all of your time bringing this nice presentation together. So I'm going to turn this over to Dr. Dart. Thank you very much.
Good afternoon, everyone. Thanks for that. Thanks to Richard for that wonderful introduction. Thanks to Richard for that wonderful introduction, which is, as you could tell, was written by my mother. Next slide. Am I doing this, or do I drive, or do you drive?
I'll drive for you.
Yeah. My competing interests are that radar system is supported by subscriptions from a wide variety as far as event reporting, government and non-government. Next slide. So here's the reason we're meeting today at a high level. This is a slightly different presentation of data that you've no doubt seen in many places, but it shows the mortality that was caused, since these come from coroners, these are actually causal implications. The top blue line tells us total overdose deaths, and you can see that starting basically in March of 2020, we did start to see an increase in overdose deaths. The teal line is opioid deaths. So you can see that a lot of things, it wasn't just opioids that went up, but we're seeing other deaths from other causes as well. And then we have the synthetic opioid deaths in burnt orange or whatever that color is, showing that it really is probably driving the contour of this curve for all the curves. But there are other causes. So I want to make those 2 points, that there's other things going on there, but a lot of it is synthetic opioids, and I'll be coming back to that later in the presentation. Next slide, please. What I do on a daily basis is what's called post-marketing surveillance of prescription opioids or prescription substances that can be misused or abused. So that would be illicit substances because they're actually prescribed. But it's important, they're many times simply a bellwether for illicit drugs. Illicit drugs is a much bigger market, if you will, in a sense. but the two usually go along together, although not always. No one's ever described well this relationship, but it's important to understand that it's a push me, pull me type of situation. And we tend to talk about one or the other, like, oh, that person abuses illicit opioids. But in reality, these populations usually are very similar. There are some people, for example, who will only abuse a legal opioid, but that preference, because it's pure and they know what they're getting, but that preference often goes away as they become more dependent on the drug. Next slide, please. Perhaps the most important concept to talk, from my perspective, to talk about today is how we do research on drug misuse in general, but especially prescription drugs. And that is that, patients and subjects are usually trying to avoid telling us that they are misusing drugs. And so it makes it a challenge. You can't really do a prospective trial because it's difficult to get approved a trial that would give drugs intentionally to patients to misuse. And so we use real world evidence, a very hot button term at FDA these days, and the concept, which is really important, of triangulation. What that means is that we can get more reliable answers to questions, especially when we're using real world evidence, by integrating the results from multiple different sources. And I've listed several of those on the page. That's not all of them by any stretch of the imagination. But the idea is to look at problems from different perspectives, and hopefully with systems that have different sources of bias. So that you may see something in one program, you need to check that and understand and make sure that it is complemented by other programs before you necessarily believe it. And I'll show you a couple of good examples of that here in just a second. Next slide, please. So one data source would be just something simple like the number of prescriptions dispensed. And here you see that for the last 10 years through 2020. It's a very interesting, right, picture, because the total opioid prescriptions increased until about 2011 and have been progressively decreasing very substantially since that time until 2020, which is fascinating to me. And you'll see that in some of the other data, but I think for us that worry about the misuse of prescription drugs, that we probably saw a change in 2020 from the trend downward over the last decade. Interestingly, at the bottom, I put total extended release prescriptions that were dispensed. And you can see that those have decreased and actually continued to decrease during the pandemic, which means that that black line is really driven by immediate release products. I've actually taken some look at this, and that looks like it's primarily a group of drugs. But I have a slide on that, so we'll come back to that in a second. Next slide, please. And here it is. So one of the programs that Radars uses is a nationally based survey that we call NMURX. And on the left side of this figure, you see high-level data that just looks at prescription opioids. You can see that similar to the prescribing data, it decreased. I should point out, this data is only from 2018. It decreased and has been decreasing for quite some time until 2020, when it even increased a little bit in the third quarter of 2020. That really surprised us. At the bottom, you can see heroin and illicit fentanyl, which rose, although not as much as I've seen other sources say. If you look at the right side of the figure, then we get into the individual pharmaceutical ingredients that drove that change. Interestingly, hydrocodone, which has gone down for a long time, went down substantially in 2020. However, that was balanced by a series of other changes. I labeled oxycodone to emphasize it because it's one of the most commonly used drugs, especially the immediate release, and it stopped going down, which was not a good sign. In fact, if you look at this, everything increased at least slightly in 2020, except for hydrocodone. So that's concerning because we've made some progress on the prescription opioids over the last decade, but I'm worried that during the pandemic, we're losing some of that control. Next slide, please. Now here's another one of our programs that we use in our triangulation, and this is called the Poison Center program. Poison centers, every state has a poison center. Your state has a poison center, and we get a lot of, you may be surprised, but we get a lot of calls about misuse of prescription opioids. And it's always somebody who has taken something and is worried about it. That doesn't mean they're going to die from it, but we use that as an indicator of misuse and the route of misuse and that type of information. So at a high level on the left, you can see a very dramatic change that occurred in 2020. And that is, we saw this substantial increase after decreasing since about 2011. So what, 8-9 years of continuous decreases suddenly reversed. Next slide, please. And when we look at those individual pharmaceutical ingredients, there's some minor observations. Buprenorphine's going up, which we expect because it's being used more and more for the treatment of opioid disorders. But what we really see that's dramatic is oxycodone. So important to remember, when a person calls a poison center, sometimes it's the healthcare facility, but more often, about 80% of the time, it's a person calling from their home or their residence. We see this marked increase in oxycodone. And I would emphasize that it actually started back in 2019. If you look at that data, I've highlighted 2020, but it was already increasing. Yeah, thank you, Richard. That's in retrospect, I think COVID has accentuated a phenomenon that's very disturbing. And we'll come to that in a second. Next slide, please. Thanks. Oh, I'm sorry, one more, Richard. Keep going. There we go. Treatment centers is another. So we have a program where about 300 different treatment center programs across the United States report to us what they hand out a questionnaire for us actually to people entering substance abuse treatment for opioids. About what, and they tell us about what drugs they're abusing, how long, where they got it, what route of administration they use, et cetera. It's fascinating. And on the left, you see this very interesting phenomenon as well, except in the other direction, where we see a decrease in 2020. Next slide, please. And when we look at the individual pharmaceutical ingredients here, you see really everything decreased. And particularly troubling to me is heroin decreased. So we have conflicting data here. Our other data systems, and there's more I haven't shown you because of time, show at least a slight increase, if not a major increase in drugs. And yet the treatment centers show a decrease. Next slide, please. So we got curious about that, and we constructed a specialized survey for the treatment centers that participate in our programs, and some of that data is shown here. To cut to the chase, I think during that first phase of the pandemic, at least 25% of about 24% of the centers actually suspended patients from entering treatment altogether, or even temporarily closed. So that's pretty impressive. And we also saw that a lot of people saw decreased patient volumes, some because of COVID reducing their staff. They were open, technically they were fully open, but they actually couldn't staff because of COVID, or decrease in people coming to the program because of COVID, which I explain on the next slide, please, Richard. These are the open-ended text responses that we received. As I mentioned, a decrease in the number of patients. And if you look down a little bit, there's a couple of concerning things. One is, and I've heard this at several different places, is we moved, centers became very generous in take-homes. Often a patient just starting on buprenorphine or methadone would very quickly go to week or even monthly take-homes, which if you're not in the field, my wife actually does this, not me. I treat toxicology patients, but it was, they felt they had to do it, but it was quite alarming because they know that increases the amount of diversion and overdoses. That's well known, and so concerning in itself. But also, I think the fifth bullet down, because the courts and the legal apparatus was not working normally, they really didn't have people being forced into treatment, if you will, through the legal system, and so their patient volumes decreased. I'm just highlighting a couple of things. I don't think these are all the reasons, to be honest, but it shows you that there was that old cliche perfect storm that was really affecting both supply and demand for opioid treatment programs. Next slide, please. So that's my introduction. And I'll just close by saying that we all know that opioid deaths are still rising, and it's just amazing to me, frankly. I've been doing this for 25 years, and you keep thinking I've seen it all, but I haven't. Right now, this is mainly due to synthetic opioids. What we found in that, I forgot to explain that rise in oxycodone in the Poison Center program. So we've drilled down on that. And when we look at the individual cases, what it looks like that is a drug called Mallinckrodt 30s. You may have heard of them. M30s, they're called, other names as well. And that's a 30 milligram immediate release. So it's a great drug for abuse because it's sort of like the old Oxycontin that you could crush between 2 spoons real quick and get 30 milligrams of oxycodone, which is not a trivial amount, of course. But what's happened, and you can actually, in our web monitoring system, we can actually see the dealers writing that they're selling it as an M30, but in the print, they actually say, this is actually fentanyl. This apparently actually makes their drug more attractive for sale because they wouldn't put it, they're not compulsive truth tellers normally. I think they do that because they think it sells more drug. So counterfeit drugs are rising, it looks like. Reminder, most patients misuse more than one drug. So every time we talk about a drug, that's not what the patient's doing, almost always. And in fact, if you look at deaths, essentially nearly all the deaths involve more than one drug. And finally, I just emphasize the point that many treatment centers were affected, although they are bouncing back, and it looks promising that they can return to where they were, although probably they will operate somewhat differently. So next, we're going to see a lot more information and much more granular and specific that I think you'll see fits with this nicely, and I'm looking forward to their presentation. Thank you.
Well, thank you very much, Dr. Dart. It was always a pleasure to see you, and we appreciate your sage intelligence and insight into what's really going on. So thank you so much. At this point, I'd like to turn it over to our other presenters, and Dr. Dana Clifton is going to lead off the presentation. And bear with us just a second. We're going to switch decks here. And let's see here. Let's get to.
Oh, I've got it.
Got it. Excellent. There you go. All right, ladies, I'm going to let you take it away.
Great. Thank you. Just going to wait for the slides to come up. Thank you so much, Richard, for the introduction, and Dr. Dart for that great, most up-to-date data. Are you all able to see my screen? Yeah, okay. So we're really excited to talk to you all today. We'll be talking to you for the next little bit. We'll try to leave some time for questions as well. But we'll be talking about the rise in hospitalizations that we've seen and kind of the change in our surrounding community related to COVID-19 and the care we have for patients with opioid use disorder. We don't have any conflicts of interest. And I think just to give a little outline, we're hoping by the end of this talk, you'll be able to, we're going to review the opioid epidemic and medication for OUD, and we'll refer to opioid use disorder as OUD throughout the talk. We're going to talk about the intersection between COVID-19 and the opioid epidemic, which will be the bulk of our talk, and how that's impacted our care for this vulnerable population. We'll talk a little bit about our experience at Duke, give some perspective from a social work perspective from Siobhan Hamilton about the impact of COVID-19 in our community, and then a little bit of conclusion with a call to action to all of you on the call, and leave some time for questions. So by the end of this discussion, we hope you'll be able to help to explain the changing landscape of the opioid epidemic, recognize the importance of medication for OUD, understand the impact of COVID-19 on the opioid epidemic broadly and at our institution, and then identify best practices for how to transition care for these patients who are hospitalized and getting them back into the outpatient community setting. And then we're going to talk a little bit about harm reduction as well. So just to provide a little bit of a lay of the land, I think some of you may be familiar with this, and just for time purposes, I may fly through it a little bit, but I think it's always important to make sure we set the stage and make sure we're all on the same page before we start. So I think we all know that the opioid epidemic is continuing to worsen, and I really appreciate Dr. Dart's most recent data showing some concerning trends, but here's some more data that we have. About 12 million Americans misused opioids in 2016. We know that opioids serve as a gateway to heroin. Opioid-related overdose deaths have increased about 200% since 2000, which is staggering. I think the most staggering statistic from my perspective is that death rates for drug overdose are on the rise, while death rates for leading causes of death in the US, like cancer and heart disease, are going down. So that's the most recent CDC data on death rates. And then there's this concerning impact of COVID-19, which we're going to talk about, and that's sort of the theme of our talk today. So you all can see here, I think we've kind of covered this, so I'll go over this briefly, but there were 3 waves of the opioid epidemic, and we're kind of in this third wave at this point, where you see the purple line, this massive rise since 2013 of synthetic opioid overdose deaths, which is fentanyl. And so this is the concerning trend we're seeing, but you can see in general, the black line, which is any opioid, is increasing as well. Just our hospital is located in North Carolina, so to give a little perspective of how we compare to the rest of the United States, this is looking at rates per 100,000, and the darker green is more concerning. So our state is in the dark green. So one of the highest drug overdose death rates. This is 2019 data from the CDC. And we know that opioids are involved in about 70 to 80% of all drug overdose deaths. Like Dr. Dart said, it's often polysubstance, but opioids are often at least one of the substances involved. And then just to give a little more context to hospital and ED visits, because we're going to be talking about that. Not surprisingly, those are on the rise as well. So national rate of opioid inpatient stays and emergency department visits over this time period have been increasing. And I think a couple truths on treatment, which I think you all are probably all aware of, but we know that medication for OUD or MOUD saves lives. So not just opioid-related mortality, but actually reduces all-cause mortality for patients with opioid use disorder. We also know that it's extremely cost effective. So there actually was a recent article hot off the presses published in the last couple of months showing the immense cost effectiveness of using MOUD for patients who have opioid use disorder. But there's still a lack of access to this medication. So a little bit of background on MOUD saving lives. Earlier studies showed about a 1/3 reduction in mortality with buprenorphine or methadone treatment. More recent data, there's systematic reviews and meta-analyses which show reduced all-cause and overdose mortality, a slight increase in mortality risk with induction phase of methadone or right after leaving treatment. Another retrospective cohort also showed reduced all-cause and opioid-related mortality for both methadone and buprenorphine. And then I'm going to hand over to Noelle to have a little bit more talk about the numbers.
Yeah, to really, thanks, Dana, to really drive home the point about how medications for opioid use disorder saves lives. I've recently come across a different way of viewing these statistics for the treatment of OUD, which I think is especially powerful. The number needed to treat is one way of incorporating data and statistics into easy to understand terms. This is the number of patients you need to treat with an intervention to prevent one bad outcome. The lower the number, the better. So treating between 2 and 3 patients with buprenorphine has been shown to prevent 1 death or relapse. And in comparison, some of the standard interventions that we internists have accepted for years have much higher number needed to treat. For instance, the number needed to treat with aspirin after a ST segment elevation MI or heart attack to prevent 1 death is 43. And the number needed to treat with warfarin and atrial fibrillation to prevent 1 stroke is 25. The bottom line is that medication for opiate use disorder has been shown to be safe, cost-effective, and has a clear mortality benefit, yet the use of MOUD remains low. Just a quick word about some of the terminology. MAT refers to medication-assisted treatment. That's medication plus counseling, where MOUD refers to medication for OUD only. We want to turn now to the intersection of COVID-19 and the opioid epidemic. This has been called the converging crises or colliding epidemics. We saw published pieces predicting a worsening in the opioid crisis in response to COVID-19, citing social isolation, a volatile drug trade, disruptions in care, financial stressors. Some discuss the public health efforts to release people early from jails and prisons to decrease overcrowding, but then worried about access to OUD treatment after release. Indeed, these worries and predictions were realized. In Richmond, Virginia, the number of non-fatal overdoses seen in an urban emergency department increased dramatically at the start of the COVID-19 pandemic. And in Kentucky, researchers looking at EMS data found that EMS runs for opioid overdoses increased by 17% after the stay-at-home orders were instituted there. This is in contrast to a decline in EMS calls for all other reasons by 20%. This Kentucky data is shown in graphic form here. On the left, you can see the EMS runs for all causes, excluding opioid overdoses, while on the right, you can see the upward trends in EMS runs for opioid overdoses.
We're going to talk a little bit about our experience at Duke. So Project Comet is what our group is called. It stands for Caring for Patients with Opioid Misuse Through Evidence-Based Treatment. We are a hybrid model, so we have a primary team and we also serve as consultants to evaluate patients who are hospitalized with opioid use disorder and withdrawal, and we're staffed by a full-time hospitalist and social worker. This is really a multidisciplinary approach to a patient with opioid use disorder. As I'm sure you all can imagine, it takes a team. And so we have our hospitalist physician who has their waiver, DAX license, our social worker, Siobhan Hamilton, who you'll be hearing from shortly. We also have pharmacists, liaison, and nurses who help us lead specifically in caring for this population. And then we collaborate with a lot of specialty services as well. The goals of our program are to start medication for OUD, for opioid use disorder and withdrawal, to increase the number of earlier safe discharges for patients who have a history of intravenous drug use. As we've learned from the literature, not all these patients have to stay in the hospital for extended periods of time. Promote harm reduction, which we'll talk about a little bit, and then connect patients to the community for ongoing treatment for OUD post-discharge.
So we began to see the effects of COVID-19 on our OUD population locally. We saw an increase in overdose-related 911 calls in Durham County, where Duke University Hospital is located. There was an increased access to our local harm reduction organizations, and our own Comet consult volume increased by upwards of 77% at times during the pandemic. This graph came from the Durham County EMS in our county and outlines data for overdoses for fiscal year 2020. In this graph, the blue bars represent the number of overdoses, and you can see in February and March, at the beginning of COVID-19, there was a lull in overdose calls. This lull also corresponds with a decline in healthcare utilization and hospital admissions. And I think you could also see that very nicely portrayed on Dr. Dart's graphs as well. The number of overdoses begins to rise substantially in May of 2020. This is the EMS data for Durham County for fiscal year 2021 through March. Here, the yellow bars represent the number of overdoses. And you can see a peak in overdoses around January of 2021. This coincides with the North Carolina COVID-19 surge. On the left is Durham County COVID-19 cases, and on the right is the same EMS overdose data. Again, the yellow bars representing overdoses. In speaking with our emergency room colleagues, we've heard anecdotal reports about the effect of COVID-19 has had in the management of OUD in the emergency room. Our OUD champion in the emergency department has relayed overall longer waiting times, making it hard to get OUD patients seen and treated. There's been less time to give resources during the emergency room encounter. And it might be that there's been a lower priority to see these patients and get them treatment due to pressing COVID-19 issues. Additionally, peer support specialists have not been able to come to the hospital in person.
And just really briefly, our own inpatient volume has also risen during this time. So when we first started in 2019, we were seeing on average 35 patients per month. In 2020, we saw an increase to 40 patients per month. And then so far in 2021, we've still had an increase, a slight lull in the beginning of 2021, but our volumes continue to be higher from when we initially started seeing patients.
So why is this trend happening? We don't have all of the answers, and it's a complex situation, but we started asking our patients about how COVID-19 has been affecting them, and we really got some fascinating answers. We heard about joblessness, increased stress, and homelessness. One man told me that he continued to be paid for his job, but there was no job site for him to go to, so he relapsed in the face of the isolation and boredom that he experienced. We heard a lot about the change in the cost and the quality of drugs. There was reports of fear of police brutality last summer. And one man told me he began purchasing higher quantities of drugs at a time for fear of losing access to the supply in his dealer. There was certainly reduced access to MOUD in the community and reduced access to in-person providers, peer support specialists, and counselors. These stories that patients have repeatedly told us about the quality and local drug supply have been documented in a report by the UN Office on Drugs and Crime, which outlines the volatility in the worldwide market. Legal trading of regular goods is needed to camouflage drug trading. So stay-at-home orders around the world disrupted trade from all angles. Supply and demand dynamics resulted in higher prices. There was a decline in the purity of drugs. And higher prices and decline in purity and quality drove some from using heroin, turning to fentanyl, or even easier to access substances like alcohol. All of this results in a higher risk of fatal overdose. I'm going to turn the presentation now over to Siobhan Hamilton, the social worker on our team, and she's going to share some of the effects COVID-19 has had on her work linking patients to community organizations.
Thank you, Noelle. Under normal circumstances, connecting patients to treatment for opioid use disorder can be challenging. And some of those challenges include, but are not limited to, financial barriers, the availability of MOUD treatment, as we mentioned, and stigma. As it relates to financial barriers, people who are uninsured or who are underinsured have limited access to affordable treatment, even when clinics have grant funding, because sometimes that funding does not include the cost of medication. And while there may be substance use treatment clinics in or near a person's hometown, those clinics may not offer medication for opioid use disorders. So that means that a person may have to travel further away to get the treatment that they need or that they want. And stigma is a barrier to accessing care. People may avoid getting medical treatment because they're afraid of being treated differently because of their substance use. And addiction is still viewed as a moral failing instead of a chronic, relapsing, but treatable brain disease. And language reinforces stigma, and it influences the clinician's perceptions about people with substance use disorders, which may then impact the care that they provide. In the setting of the pandemic, connecting people to treatment for opioid use disorder was even more challenging. Early on, clinics made operational changes that were designed to keep staff and patients safe. And some of those changes resulted in delayed access to treatment. And very similar to what Dr. Dart had mentioned regarding the surveys from the treatment centers, these changes included things like changing hours of operation, suspending new referrals, or only taking referrals from select entities like crisis centers, cutting down on the number of on-site groups, or having limited availability of staff and providers, which led to longer waits to get into treatment. Within a few months, clinics made further adjustments based on CDC guidance and SAMHSA recommendations. For example, clinics increased access to telemedicine to include video and telephone appointments for new buprenorphine patients. Telemedicine worked really well for a number of our patients, especially those who lived in rural areas or who lacked reliable transportation. However, for others, technology gaps prevented them from participating in telemedicine visits. And examples of these gaps included things like not having a laptop or smartphone, having unreliable broadband access, or having insufficient minutes to participate in telemedicine groups. The methadone clinics still required in-person appointments for patients, and those clinics had flexibility to offer 14 days of take-home medication to people who were less stable in their recoveries, or 28 days of medication to people who were more stable. However, very few of our Duke patients on methadone were given extended take-home medication, and most of them would still attend the clinics daily or receive take-home medication every other day or only on weekends. We also experienced longer waits to get people into inpatient residential treatment. Agencies reduced their capacities to create space for quarantined residents or new admissions, and some congregate care programs stopped taking new referrals altogether. In-person self-help group meetings were suspended temporarily, and many were moved to an online format. Prior to the pandemic, local peer support specialists could visit patients in the hospital rooms to initiate engagements, but with visitor restrictions in place, they could no longer do that. They were also not able to pick people up and transport them to their appointments once they left the hospital, at least in Durham. And harm reduction programs limited in-person contacts at fixed sites, and some of those fixed sites were closed. But because they still operated mobile exchanges, they were able to offer curbside pickup to distribute new or pick up old supplies. Also, a key message in harm reduction is to not use alone. However, social distancing increased the likelihood that people would use in isolation, overdose alone, and not have anyone around to administer naloxone. Prior to the pandemic, patients who required a long course of IV antibiotics could transition to a skilled nursing facility to complete their treatment. But during COVID-19, it became more difficult to refer people to skilled nursing facilities. Some of these difficulties were because skilled nursing facilities had shifted their focus to caring for patients who tested positive for the virus. Facilities also had staffing shortages and worked to maintain appropriate staff to resident ratios. They reduced their census to allow space for quarantine, but also to reduce the burden on and burnout among staff who were caring for residents. And facilities had started to request longer bridge prescriptions for Suboxone for those patients who could transfer, because they didn't want to transfer residents to outpatient appointments and risk exposing them to the virus. And patients themselves often declined referrals to skilled nursing facilities because they were afraid of contracting the virus. I'll turn the presentation over to Dana.
Thanks. So I think you've seen a lot of the challenges that we've encountered as a result of impacts kind of nationally, but also on our specific program at our local institution. But there are a lot of opportunities that we've also seen as a result of COVID-19 that hopefully we can continue to make lasting improvements on. So federal agencies have made some good changes, relaxing restrictions for take-home methadone, increasing televisits for those who are able to do televisits and don't have to travel as far. Additionally, a very recent change, the Department of Health and Human Services removed some of the barriers, the training required to prescribe buprenorphine in the community. So you no longer have to have the training to get your DAX license, which is a massive change to hopefully increase the number of providers to prescribe buprenorphine. There still is more to do. So we know that medication for OUD has substantial mortality benefits, and we know that the opioid epidemic is worsening in the setting of COVID-19. So we must increase the use of medication for OUD and the access to this medication, encouraging providers to prescribe, but also patients to access this medication. We must ease regulations on skilled nursing facilities to allow them to dispense these life-saving medications for opioid use disorder. We need to make naloxone or Narcan more affordable and accessible, make it available without a prescription in North Carolina pharmacies and elsewhere. Still costs a fair amount for patients to get this life-saving medication without insurance. And we should be advocating for harm reduction coalitions and promoting harm reduction in our own settings. We know that harm reduction is necessary because we know opioid use disorder is a chronic and relapsing disease, as we've talked about. And so relapse is a normal part of the process. And so we need to talk about harm reduction. So there was a recent North Carolina bill to undermine syringe exchange service programs, and we successfully advocated for the bill not to get passed. So harm reduction incorporates a lot of things, and I'm just going to very briefly touch on a few of the important things. But I think we've all been talking about how opioid use disorder and substance use disorders in general are lifelong and chronic. It's not uncommon to return to use, and we shouldn't be punishing patients or stigmatizing them as a result. Just like alcohol use disorder or recurrent DKA or coming into the hospital for other recurrent medical issues, trying to normalize this as a part of the disease process. And so as a result, we need to talk about how to access clean needles, how to exchange syringes to reduce the risk of infectious transmission related to IV drug use. Discuss the environment of use, so talking about not using alone, making sure that patient or family members who live with the person with OUD have access to naloxone and know how to use it. Knowing to test for fentanyl, we've seen a lot about the change in drug supply, the increase in fentanyl overdose deaths. So teaching patients how to test for fentanyl in their supply so that they're at lower risk of overdose. These are all things we can do to reduce harm from opioids. As providers, what can we do? So we can promote more judicious opioid prescribing practices. Just merely recognizing and diagnosing someone with opioid use disorder and withdrawal can go a long way to help identify them and figure out who would benefit from treatment and referral. So oftentimes these patients are just going undiagnosed. Managing withdrawal symptoms, we should be using buprenorphine and methadone to manage withdrawal. Promote safety of patients while are hospitalized and following discharge. Encourage harm reduction like we talked about. Reducing the use of stigmatizing language. So really talking about opioid use disorder and other substance use disorders as diseases, and taking away blame and choice and willpower, because that's not what this is about. And so trying to talk about that with the patient and family members and those who care for the patients as well. Educating learners and trainees, so teaching them how to care for patients with opioid use disorder so that this continues on. Making sure to address social determinants of health, and then making sure we connect patients to the community for ongoing treatment post-discharge. And we appreciate your attention, and we can try to address some questions in the few minutes we have left in the chat.
Excellent. Thank you, ladies. Great presentation. I'm waiting for my video to come back up here. Good grief. There we go. Thank you. We have a couple of questions in the chat room. I'm going to post one up here. Let's see. I'll take it from newest to latest. Is there any prioritizing of vaccination of patients with OUD in your county?
That's a great question. There is not a prioritization for those patients in our county.
Okay, interesting. We have another one that says, I'm an MD in Brazil. We do not have the same opioid problems as the US. How often American patients with OUD take illegal fentanyl thinking they're taking heroin? Does it play a role in the high rate of overdoses?
Yeah, I think, there's one graph I didn't show that really showed that another graphic depiction of the spike in synthetic opioids. I think anecdotally, a lot of patients I talk to do not realize that fentanyl is in their supply in cocaine, in heroin, and other, not just in opioids. So patients are not realizing that fentanyl is in the supply. Sometimes they do know, but I think a lot of the times the patients are not aware. And so that definitely increases the risk. And then just the potency, I think, and the changes in drug supply can really impact that as well.
Okay.
The fentanyl test strips that are available through harm reduction centers are really a powerful tool that patients themselves can take control, have some knowledge to know that they definitely shouldn't use alone if their supply is tainted with fentanyl, to have naloxone available and maybe to use in a smaller quantity at the beginning. But I think of those as being something the patient can have control over when they may not have much other control.
Do you have any specific data on veterans?
I don't have that data specifically. We do have a Durham VA hospital, which is right across the street from Duke, but we don't have the data for them specifically. Sorry.
Okay. And I have a question for myself. How difficult was it to manage patients on pain who are also battling substance use disorders? And how difficult was it during COVID?
Yeah, I think it's always very challenging to manage pain in patients with opioid use disorder. I think we know that they're going to have high requirements. And I think sometimes because of stigmatization, people don't want to treat their pain, which is not appropriate. And so I think it's very challenging. On the one hand, you want to make sure you're treating pain appropriately so patients don't want to be at risk of returning to use because of pain, but you also want to try to keep the patient safe. And so be judicious about the opioids you're giving. And so I think that can be a hard balancing act. I think one thing we've learned is that we should always continue medications for OUD no matter what, and then treat pain or perioperative management on top of those medications. So we should never be stopping those in patients with pain or patients getting surgery.
Okay, excellent. Well, let's see, we have another one. What is your perception regarding the rising trend in Duke Hospital? And if, I can't read it, if redist is happening? If I can have Mr. Barros or Dr. Barros, please retype that. It says, and if redist is happening in the rest of the US. I'm sorry, let's reread it. What is your perception regarding the rising trend in Duke Hospital and the rest of what's happening in the rest of the United States? Okay.
Yeah, that's a good question. When we were preparing for this talk, we were looking around for other data because we knew that our audience would be from other parts of the world besides North Carolina. So the two articles that I highlighted, the one from Kentucky with the EMS data and the one from Virginia, was all I could find about trends, but I think maybe that speaks to similar trends elsewhere in the country, at least in the southeastern United States.
Okay. Very good. Excellent. If we have any more questions, we'll be happy to take them. No, I guess that's it. Well, I'd like to thank every one of our presenters, Dr. Clifton, Dr. Ivy, soon to be Dr. Hamilton, and of course, Dr. Dart for joining us today. We're really thrilled to have your presentation. The slides will be posted up on the Journal of Emergency Management webinar website. Additionally, we will be sending everybody who's attended the webinar a post-conference survey with links to the handouts and slides. We apologize for the early technical issues with the runaway slide deck. That happens sometimes. People put gremlins in the PowerPoints. Again, I'd love to thank our panelists for joining us. You guys are in the trenches doing incredible work during incredible time. And in the tail end of the slide deck, you'll have our introductory slides. You'll have the slide deck from these lovely ladies here. You'll have Dr. Dart's slides, and you'll actually have a copy of the article that Dr. Clifton and Dr. Ivy wrote for the Journal of Opioid Management that ran in our January-February 2021 issue. So if we have any other questions, I guess not. I want to thank you all for joining us today. We appreciate it. As I said, please fill out the survey so that we can learn how we can do a better job on our webinars going forward. Thank you so much. Stay well.